Kama kawaida, mabibi na mabwana, welcome to Daktari ya Quick One. As usual, I'm your host, Dr. Nyadimu, and this is actually going to be one of the most exciting episodes I've ever done because I've been looking forward to it for a long time. Because my guest today actually requires no introduction because most of that, or if you don't know him, I don't know, you might be in the wrong field if you're a medic. Yeah, and I think he's also touched so many lives in terms of patients and out there. None other than Dr. Oburu himself, Ezekiel. Daktari.
Yes.
Karibu.
Asante sana.
Welcome to Daktari ya Quick One. Yeah, we are an online podcast that like to give doctors a platform to not only express themselves, but we discuss some of the pertinent issues in medicine.
Good.
So that we can get long-lasting solutions. By talking, we solve a lot.
That's true.
So it's a pleasure to have you. Actually,
it's a pleasure to be here.
Yeah. I've really looked forward to this, and I'm humbled that you're here in the first place. So karibu.
The pleasure is mine.
Yeah. So I don't know. We know you as Dr. Oburu Ezekiel, the orthopedic surgeon.
Mm-hmm.
Our teacher, both in class and online.
Mm-hmm.
And our doctor as well. Orthopedic. How else would you like to be introduced?
Well, that's it, really. I think, that's well, more or less it.
I've said everything. Hakuna mambo nimeacha.
Well, I'm also a father, so I think that that is that's important.
Yeah, that's important. Congratulations on being a father. Some of us are still running away from that responsibility.
The best thing that can happen to any human being.
Really? So to say happy?
No, it's a fantastic. You will never regret. Yeah.
I don't know. So for doctors, I think it's usually quite a challenge. I mean, most doctors postpone starting families because of the nature of the job. How do you handle? How did you manage to? How did you start? When did you start in your career?
I think that it's. I don't think there is any formula really. I think when the time is right, whatever that means. When you feel, you'll never. I think the reason why people postpone is because they feel that they need to be able to have a certain amount of money to be able to.
Yeah.
And then when you say that, it means that only people with money can have children, which is not true.
Which is not true.
Children are children. And sometimes I think it's because we think that when you are when you need. Children need a lot of money. Of course, children are expensive. That's true. But a child, the good thing with a child is that they don't have a perception of money. As long as they're with their father or with their mother, they can't see that. And thank goodness they can't. They can't see class. They can't see.
As long as they feel happy, loved.
That's true.
But then now, that's the thing, because it is for like doctors, for example. You finish med school and you're up and about with your hassles. Then you're going back to postgrad. And people, I think, from what I've gotten, most people want to start families when they're a number of years into their maybe postgrad so that they can maybe have time or something. I don't know. You don't feel that?
I look, there's no formula.
There's no formula.
There are some of my classmates who got married when they're in med school. Yeah, there's some who got married after med school. I presume there could be one or two who are not married up to now. So there is no formula. But I think that your life, medicine should not define who you are.
Yeah.
Medicine is part of your life. You're a human being before medicine. You have various needs. You have family, you have parents, you probably have a wife, you have a children, and your family does not. Your mother doesn't see you as a doctor; they just see you as a son. And I think that's an important thing. The problem with medicine is very insulating, and there's a big deal about competence and what. So we as doctors sometimes just feel special,
Mm.
and we should. We're just
Yeah.
like anybody else. Yes.
But they say it's a calling, because I'm trying to. Sometimes I picture my own life. Yeah. Most of the time, as a young doctor, there is probably an exam that you're doing somewhere. There's maybe an exam you're studying for, and at the same time you're still working. So you find most of the time you're at work. When you come back in the evening, you need to study. Maybe there's a CM you need to attend. So you find that most of your life is just revolving around medicine.
I think it is, but it doesn't make it any more special than any other
Than any other
career.
career.
I don't think so. I don't look at medicine as being special than being a lawyer or a teacher. I think it's a job like any other.
Yeah.
And I don't really wonder whether it's a calling or not. I think all jobs are callings, if you want to put it that way. I don't see anything special with it. I think, is it a big deal if things go wrong in medicine? Of course, it's a big deal.
It is, yeah.
You understand? If somebody didn't like the house, how it's been designed by an architect, but if somebody loses their life,
It is big.
it is a big deal.
Yeah.
If a complication happens to a patient, yes, it is. But I think you should just do your job well. Of course, you should be careful because you're dealing with human life. Is it special as compared to other professions? In my humble opinion, no. Yeah.
Really? I think most people, the government would really disagree with you, especially when it comes to times for strike.
I think that the consequences are
more dire.
Yeah.
If
but you see, if the system fails in terms of the military, the consequences would be more dire.
Yeah.
You understand?
Yeah.
If the system fails with regards to roads and bridges, the consequences would be more dire.
Yeah.
There's also an emotional aspect to it. Yeah. If the system fails in terms of the country not being run properly, the consequences are pretty dire because you don't alleviate. Yeah, you understand? So I just don't see it as being particularly very special.
So we shouldn't base our lives on just that. Right?
I don't think so. I think you should live a more wholesome
holistic life.
Yeah.
Well, I don't know. Personally, I find it a bit hard. I don't know.
I think so, and I think
also agree with that.
If I would be asked what I would do differently, I think we as medical students, when I was a medical student, that was a long time ago in the 90s, I think it's important that we interact with many other people that are not in our profession.
Yeah.
Because you interact with doctors, you do internship with doctors, your peers, they move on, they start families and everything, who are in other professions.
They actually move on while you're still in med school.
Yes.
Yeah.
And so you don't interact with them. Then you finish that, and then you go to train as a postgraduate. Then you finish as a postgraduate, and you start working as a consultant. So your life is surrounded by, and also medicine as a profession is a very hierarchy-based profession. So there is the consultant, who supposedly knows it all. Then there is other consultants who are probably younger than him.
Then
there's the registrar, the senior registrars, the junior registrars, and the intern, then the medical, the intern, then sometimes medical officers ahead of the interns, and then you have the medical students, and then also you have other cadres of training, the clinical officers. So, and then you have throw into the mix nurses and the matrons and other senior nurses and the trainee nurses. So it's really based on hierarchy, and that I think can be isolating.
Yeah, and then you always everybody wants to be
at the top.
And
whatever that means,
which is elusive because there's always something better.
Yeah, that's true.
So anyway, I don't know. It's I think it's important that we try balance, but I think you guys as our mentors, because we are told when in med school, I remember, and I've talked about this on the show before. For example, for us in Maseno, in medical school, it was really frowned upon for a medical student to be seen doing things that are outside medicine.
Like what?
You're expected to be fully in class, like politics.
Okay.
Student politics, student leadership. It was almost illegal, because you'd find if you're in that side, the administration just identifies you and comes for you in the exam.
I think that's a myth. It is.
A myth?
Yeah, it is. I think so, because I teach at the medical school, and no lecture is after another student. And then I always tell students, you're not that important.
You're not that important.
You're not that great. You're not. No one, to be honest, cares so much about you. Whether you do politics or not, I honestly.
So you think that was in our mind?
That was in your mind.
Really?
Yeah, and it is. It is. You know, sometimes we can have an exaggerated opinion of our importance. No lecturer wakes up to go and target a medical student. They are just honestly not that important, and I think that's good for them to realize.
Yeah.
We don't even target postgraduate students. We don't. We don't. You know.
Is that for all lecturers? Because
I think so. I just don't think that, and not because we are necessarily good. First, I think people one is malicious. But why would you target an undergraduate?
What benefit? Much junior.
Yeah. And also, why would you target a postgraduate?
But isn't it like a role of you as a teacher of medicine to ensure that the product you're churning out is, quote unquote, worth of being a doctor?
I think so. It's competent. I think you understand what I'm saying. I don't think there's any specialness about being a doctor, but I think the product that we're churning should be competent.
Yeah.
Now,
is the competency purely academic, or does character play a role? Like the character?
I think it's probably both. But I can tell you, we tend to be objective.
So
if somebody has made it to the exam,
and then,
you judge them by the exam. There is nothing. I can tell you, I've been privy to a number of meetings after we have conducted an exam.
The Senate exam, meetings.
Not Senate meetings, just departmental meetings.
Oh, okay. Oh.
And no one is interested in an undergraduate failing. In fact, sometimes they want to help the undergraduate. Many times, where no one is interested. I think undergraduates have an exaggerated opinion of their importance.
Sense of importance.
No one will ever be interested in making an undergraduate fail. No.
So there's no witch hunt whatsoever.
Not in the list. I don't know. Maybe in the past there was.
Because
but that's what I believed when I was an undergraduate. Even when I was an undergraduate and I finished undergraduate a long time ago, in 1998, there was just no witch hunt. No one has that time to be honest, allow me to use nonsense. No one has that time for going after you.
Because people have their own lives.
They have their own lives. I mean, I've got kids and I've got my own things I'm doing.
There was a book I was reading. Was it Yuval or was it Atomic Habits? And it says that people actually have that exaggerated sense of importance. You look at yourself and you think everybody has
no.
Yet everybody else is thinking the same. So actually everybody is more into their own.
No one has time for that.
Yeah. So you need to.
I think anyone who thinks that the lecturer is going to go after you because they saw you partying in a place, or first number one, they are unlikely to.
Or you took his girlfriend.
Or even you are speaking, you are rude.
Yeah.
No. And then also the exams are anonymous because it's a number.
What about the OSCEs?
They are distributed and there's randomly.
But then we always have this that, hey, nisipate huyo lecturer.
I think that in the past, when the exams were not OSCE based, I think it's
when it was long case, short case.
Yes, when it was long case, short case, those are difficult to be extremely objective.
Yeah.
It's still possible, but I think sometimes the teachers need to go for training. And sometimes we were not taught, and then you cannot teach an old dog new tricks, and blah blah blah. So those sometimes were not as objective. But OSCE, everyone is being asked the same questions.
So OSCEs are objective, 100%? Okay, not 100%.
Yes, and not.
They are more objective than
look, we are evolving, we are learning.
Yeah.
Are there times when you could see a student who knows absolutely nothing and they're prompted? A little.
Yeah.
And maybe in another station somebody's not being prompted.
Exactly. Yeah.
But they are objective. No one is interested in failing an undergraduate. My words.
Let that sink in.
No one is interested.
I hope that the students listen to this, because I think even in postgrad, you'll find people really, they try to avoid
no.
lecturers.
You see, once you've already made it to the exam, no one can help you and no one can fail you. Because like in my postgraduate, I exam in orthopedics, the postgraduate go through one long case, so to speak, and they go through 5 stations of OSCE, like, orals. So supposing I didn't like you, and I scored you 20%.
That is possible, yeah.
Well, unlikely. I'll be fair, and I scored you 20% in an OSCE. You still have 4 other OSCEs, 4 other oral stations,
4 other stations to balance out. Yeah. But it could be that one station is supposed to save you. You get a 49, and you're just like,
I can tell you, no one is out to be malicious. Just banish that off your head.
Yeah. I hope we can do that.
Is it something you knew, or you thought that people are malicious?
No, I think it's gone round.
It's a myth.
In circle. It's a myth.
It's a myth. Yeah, it is, because
you've never had a statement of like, I'll make sure you will never become an orthopedic surgeon. You'll never become a doctor. I'll make sure.
I've heard of that, but even those people saying that have an exaggerated opinion of
themselves.
No one does. I think that I'll never forget when I was doing my fellowship exam in Dublin. There goes my Jaluo myself. So and I was seated the day before before my clinical exams. I was seated in my room in Dublin.
Fellowship do exams?
Fellowship orthopedic, or the Royal College of Surgeons.
Oh, okay.
Yeah, the fellowship orthopedic, the exit exam. Yeah, the exit exam.
Okay.
So I was sitting in my room in Dublin, and I can't remember. I was trying to revise something, and I can't remember if CNN was on or something. And when I was seated there, and I said to myself, "Wow, look at my life. It has come to a standstill right now." But all over the world was 7 million people at that time. People are moving.
Everything is moving.
We were how many students? We were how many doctors who are coming to sit for that exam in Dublin? I don't know how many we were. Maybe we were 50. Maybe we were 60. Maybe, I don't know.
But you were just focusing.
But that was such a small part in the world that really it didn't matter. But for me, that was it. And that sometimes is what we view ourselves as doctors. We see the world in a little paradigm of medicine. The world is so much bigger than
going around us.
Yeah.
Okay, I hope doctors can begin to have such a perspective, so we reduce our sense of importance.
I think we should. That's my opinion. I don't mean that you're not important, but I just don't think that suddenly no one is out to target you. I'm not, and I don't think there are any lecturers who are out to target you. They have so many things in their mind.
Yeah, they have families. They have patients.
Yeah. Some of them have golf.
Yeah.
No one is interested in targeting you.
Okay. That's a good message, at least. So speaking of medical students, you say you were a medical student. You finished in 98.
In 1998, yes.
Wow, I was 2. I was 4 years old.
Yeah, that's a long time ago.
That's when you now became a doctor from UN. Then ortho?
No, then general surgery. I did general surgery.
Oh.
I did internship. I got myself into the system after internship. So I finished my internship on Friday and I was in class on Monday. And
Really?
I did general surgery for 4 years.
4 years.
And then after that I worked for like a year. Then I went to do orthopedic surgery.
That's as a fellowship?
So I did general surgery in University of Nairobi, so Kenyatta Hospital. But then I went to do my orthopedic training in the west of Scotland.
Oh,
So I did general surgery from 1990, from around 99, end of 99 to 2004. Then I did orthopedics from 2005 to 2011 in the west of Scotland. Then I had an 8-month stint in Australia. And later I went to a 6-month stint in Baltimore doing foot surgery and another 6 months stint in Stoke-on-Trent doing shoulder surgery. So I've been around.
You are quite accomplished, Daktari.
I'm not sure it's accomplished. I've just been around.
No, but I mean, so wait, let's pull up. You kind of sort of rushed through all that. You rushed through, I think, is it 20 years?
Yeah, it's
because you're
18 years of training.
18 years. So you finished, you said something quite interesting. You finished your internship on Friday and you're in class on Monday?
Yeah, I was in class doing general surgery because we used to do, and it's still there up to now, we used to do 1 year of theory stuff. And then
in general surgery. How is that? Because I think most postgraduate programs I've seen, they want you to have at least 1 year post-internship, things like that. That wasn't there? Or
it was not there, but somehow it was there.
It was there,
but I got myself into the system.
You bypassed the system.
So it's not there everywhere. In Kenya it was. It wasn't official.
Oh, it wasn't official? No, it's not like a must.
You must know.
So you never practiced as an MO?
No, I never did.
How is that? That must be... So you've been a surgeon all your life?
Technically. Do I think it matters? No.
I think it matters.
Why?
I think it matters because, and I've talked about this more than once on this show, that this phase of MOs for doctors, I think it's rather useless phase in life.
Okay.
Yeah, because unless you've decided that you just want to be a general doctor your entire life, then that becomes an important part. But if you're targeting for people to specialize, I think yours is a better route. Because you see all that you've done, 18 years of training. So maybe you finished med school at, was it 25, 28? There?
26, 27.
Yeah, thereabout. You've done foot surgeries, shoulder surgeries. Those are subspecialties.
Yeah.
At quite not a very advanced age. Because
no, I did actually. So I went to do my foot surgery. When I went to do my foot surgery, I was 44. I think because I'd worked as an orthopedic surgeon for a while.
Yeah.
So I don't think it matters. Sometimes age. I think it's more determination and deciding what I'll do.
But you see, the older you get, the more the determination goes away.
But then again, I think also you have to evaluate yourself and see. You have to determine whether or not you will you can reinvent yourself. You know, I think that especially with things like AI now, I think that the world all over people are reinventing themselves. And we doctors, we are taught that you go to undergraduate, you finish undergraduate, you go to postgraduate, you finish, then you work like that for the rest of your life. I think that we may need to change things, tweak things a little bit. So like I trained in general surgery, in orthopedics in the UK, and most of my training was doing hip and knee replacements. When I came to Kenya, I realized, hey, look here, no one is going to refer those patients to me. Yeah, they're going to do them. So that's why I thought, let me do something different. Foot surgery. So I still do my hip and knee replacements. But I get referred quite a few complex foot cases.
Okay, so now you specialize in foot.
I do as a
And
subspecialty,
as a
but I still do hips and knees and
Yeah.
shoulders and
Long bones.
Yeah, I do trauma.
Uh,
I do not as much.
Not as much.
But I do
yeah, because
some.
you're quite big on social media on the and we see you.
You'll hardly see a trauma case.
Yeah, I've never actually seen.
Yeah,
that's one of the things.
No, I do. I do. Not as much.
Mm.
I do. You know, I still do like maybe a femoral nail or a tibial nail or
once in a while,
or at least frank or even a complex elbow injury.
Mm-hmm.
Yeah,
but mostly you're in the. For me, I see it as because let me tell you my story about with ortho. Well, we did the ortho rotation in 5th year, year 5, and before we joined, we really didn't know much about orthopedics. But then going through the process, it's a public hospital. Most cases are trauma.
Yes.
Most cases are trauma accidents, and it's traction and nails and all that. So after the rotation, I remember 2 of my friends, actually 3, the very big guys in class. They were like, we have found our home. This is home. Because our perspective that time was ortho is muscle.
That's that is absolutely not true.
And power. Yeah. But then I started watching an orthopedic surgeon, steroid injections. I mean, things are just not as...
No. There is no even surgery, muscle doesn't help.
Yeah.
I mean, it may help sometimes. No. I mean, orthopedics are so many specialties, subspecialties. So the spine surgery, muscle will not help you there. There is foot surgery, muscle will not help you there. There is hand surgery, muscle will not help you there. There is pediatric orthopedics, muscle will not help you there. There is shoulder surgery, muscle will not help you there. Where there is general trauma, that muscle will not help you doing a complex proximal humerus fracture. It will not help you. It will frustrate you.
Yeah.
There's arthroplasty. Where hip and knee replacement, muscle does not help. It may very occasionally help you in a hip replacement. Very, very, very occasionally help you in a hip replacement. Once in 200-300 hips.
Yeah.
Now, and trauma, muscle doesn't help. It may help in old trauma.
Yeah.
Trauma. Yeah, in old trauma. But if you have a femoral distractor, it doesn't matter how strong somebody is. Muscle cannot help.
Yeah. That's now what I came to realize later. Did my internship in Makindu. We had Dr. Mwoki there.
Yeah, I know the guy.
Yeah, and I started to realize, okay,
there's no muscle.
It's not.
Muscle will not help you in releasing a carpal tunnel.
Exactly.
It will not.
Exactly.
Either you know how to do it or not. In fact, sometimes I've had teaching a young orthopedic surgeon how to do a hip replacement. First, number one, people assume if you're big, you're muscular, which is not true. You can be very lean and very strong, stronger than somebody who is big, who is just big. So I have taught people doing a hip replacement, and there's one I remember. One of my young surgeons, I was teaching him, and this guy was really big. And it was, but reducing at that time, reducing the fracture, the hip replacement, he couldn't do it. And I couldn't have a go. And I go and it's technique.
It's more of technique.
Yeah,
I realized that. And one of my current orthopedic surgeons, I work in surgical department. One of them is a lady.
Yeah.
And she's quite small.
Yeah.
She's quite small, but then she does it. So, I think...
Yeah, in fact, those ones are usually better. They know how to do it. And you're not doing the pulling.
Yeah.
And instructing somebody, could you pull this?
Yeah. And, I think it's a misconception that's out
there. No, it is. It's a terrible myth.
Yeah. That ortho guy has to be huge and all that. So we find most ladies really, they hear ortho, and even when you're working with them in...
I know.
Even outpatient casualty, they'll see an ortho case and they just look for you. They're like, mini dame. Why am I doing
No.
Yeah, so I think ladies out there, lady doctors, you can do it.
Oh yeah, of course.
And as you're mentioning subspecialties, like the things you do, do you even need any implants? No.
Yeah. So orthopedics is so wide.
Yeah.
So you need implants for many things.
Yeah.
Shoulder surgery, hip, knees.
But now the foot, because most of your surgery, your knees, I see it's just small manipulations here and there, arthroscopy, injections.
There's only so much you can show in a video.
Yeah.
Especially that's there for the lay public.
Oh, okay.
There's so much. I can't start showing them the gory things of this is this and this is that. First, they won't understand, but also.
Yeah. How is it for you? You really seem to enjoy what you do.
I do. I really do. I really enjoy operating. I really enjoy teaching. Yeah, both.
How do we get there? Because for you, let me just ask this. Just take you back. Did you, from this word go from med school, did you always know that surgery was your pathway?
No, I wanted to become a physician.
You did?
So I got into surgery because I thought I'd probably earn a better living than that in surgery, which is a wrong reason. But I've grown to like it.
Yeah.
Could I have made a good physician? Probably. I don't know. My mind is so surgical now.
Yeah, it's
in how I see things.
Mechanical thinking.
Yeah, I see, can we fix this problem? If you can't fix it, then well, we better tell the patient. So my mind is so sad, but I wasn't going to become a surgeon.
You wanted to become a physician.
Yeah, renal physician.
So you went into surgery for the chums.
So to speak.
So to speak.
Yeah. But I've grown to like it.
Yeah. It grows on to.
I don't do. I think among the orthopedic surgeons who make the most money are spine surgeons. I don't do spine. I don't do spine surgery. No.
So how does this passion come around? Because most of us, like for me, I've always thought I want to do surgery. But I'm in this medical officer phase, and I'm like, anything that comes, I will do.
And I don't think that is entirely wrong. I think that people say you have to have passion for something. If you don't have passion, then it's going to become difficult. But I think you can learn. You get what I'm saying? You can learn to like something. When I got into orthopedics, I wasn't like a great fan of orthopedics, but I love it now. I think you can learn to love something. I don't know. For maybe this is a wrong definition, but it's like, you can meet a girl and be hopeless in love with them, and you get married and things don't work out.
Yeah.
But you can also have a girl where your mother told you marry this girl, and vice versa, boys too.
You accidentally got her.
And no. It's got nothing to do with it. It's an arranged marriage.
Yeah. Oh, yeah.
It's an arranged marriage.
And people say those are the ones that work.
I don't know. Who knows? But you just learn that this is what you're supposed to do, and
so the passion comes.
It does. It does. It can either be something that was there from before, but it can also be something that's acquired.
Yeah. There's something we were talking about mastery. There's a book by Robert Wingward, Mastery, and he says that you need to do the same thing over to say that you're perfect.
Yeah.
Or to be,
and you like it. At the end of the day, a primary job is providing for my children. That's my career. So anything that enables me to do that, I certainly will.
Yeah. And how? So you teach and you also practice. So practice is private.
Yes.
It's really private. How is that? How is private practice like? How do you start one? Because some people struggle out here with employment for a long time.
I think that they do, but it's not just you. I think medicine is a business. That's number one. We look at medicine as, you're competent and everything. And that still is what it is in many countries. If you go to the UK, you work for the NHS. But also medicine is a business, and you're competing with other doctors, with clinical officers, with nurses. So that's one thing that you should know.
It's a business.
It is.
So
I hate to say it. I always believe that if you're competent, patients will come to you.
Yeah, if you're good.
If you're very good. That's partly true, but not 100% true.
And by saying good, or competent. You know, there are people who you can be not maybe, as you said, you're competing in terms of maybe skill and all that. You might not be exceptional, but the way you talk to people,
Yeah, and that happens in medicine.
yourself.
You understand? Because you must realize that there's some things in medicine where you really need to be skilled.
Yeah, yeah,
There are some operations where you need to have been shown how to do those operations.
to be able to.
But by and large, most surgeries are mundane.
Mundane, by that you mean?
Just running the mill. Everyday distal radius, ankle fracture, straightforward. So any orthopedic surgeon worth his salt will be able to do it.
We'll do
Now the real complex things, those are not common.
Which are what you do.
I do both.
But so what sets you aside is these very soft, more softer skills, yeah, more specialized things. Like
I think it helps, but I can tell you. So do I do a lot of complex foot surgery? I do. I do some complex elbow sometimes and shoulder.
the arthroscopies, you also do a lot of.
Yeah, I do a lot of arthroscopies. Yeah. Not the most complex of operations that I do. There are others that are much more complex.
What's the most complex surgery you do or you've ever done?
It's really difficult to say. It really varies. Some trauma can be complex.
Trauma. Yeah, somebody had asked me. I told them I was going to talk to an orthopedic, and they wanted to know what is the most traumatizing thing you've seen when it comes to surgery, trauma, and patient comes and you're like, oh, this is bad.
It really varies. I mean, I've been practicing for long. I think gas gangrene. That is.
Gas gangrene is.
That is. I can. Yeah. If I see a patient with gas gangrene, very easy for me to say that this patient is gonna die.
But in ortho, you really don't lose a lot of patients, do you?
We don't. But there's some things like gas gangrene. I remember seeing a patient once.
I've not seen a case of gas gangrene.
It's not easy to spot. Especially not seen. I remember seeing a patient once, and I was called by someone. It was actually, we have a patient with query compartment syndrome. Send me the pictures.
It presents like compartment syndrome.
I said, this looks like gas gangrene. And I rushed to the hospital. I saw the patient. And I said, wow, this could be gas gangrene. And within time, I said, are the relatives aware? And we rushed the patient to theater, but the patient did not make it.
Which part of the body was this?
It was in the limb. It spreads quick. I've seen it here. I've seen it in the UK.
It's that quick?
Patient, it kills. Gas gangrene, when you see it, you know that it's a ticking time. I've seen it in the UK. The patient came, saying, wow, this looks like gas gangrene.
I really don't know about gas. I need to read about that. I don't know much about it because
it's rare.
It's a rare thing.
It's very rare.
Okay. So that's the worst thing you've seen. In terms of, you don't do a lot of trauma.
I do trauma sometimes. I'm not as much.
Yeah. But what about the amputated, the crushed limbs? Because for me, I think that is sometimes
that's sad. That is sad.
But not really scary because you just amputate.
Well, it's sad for anyone to lose their limb. So
not life-threatening.
It's sad. There's always an emotional aspect of it.
You're attached to your limb and all that. Yeah. So teaching. Did you start teaching right away? From how long have you taught?
Well, I've always loved to teach. Even when I was in high school, I used to coach maths to somebody.
High school? A fellow high school?
No, somebody who was in a junior class. I taught my brother too.
Okay.
Yeah. So for me, teaching is something I love. And also, I had very good teachers, postgraduate teachers, especially when I went to the UK. So I'm passionate about just passing. I don't believe anyone should hoard knowledge.
Pass knowledge to the
become
next
better.
person. Yeah, as the more you teach, you become better. So you've taught since when?
So I've really taught since 2005, on and off. Yeah, on and off. I love it. I love the whole thing.
But at the university?
Around that time, I became a tutorial fellow in 2000. Obviously, when I was away for many years, I didn't teach.
You didn't teach. Okay. Oh, but you were still attached to the UN.
Yes, I was.
So when you came back, it was just a matter of continuation. Which one do you like teaching more, undergrads or post?
Initially, I loved to teach undergrads, and I still do when I'm in the element. I had a lesson with some on Friday and Thursday last week. So I really like it because when I was in undergrad, I remember going for ward rounds, and the teacher could talk about all these very esoteric topics that I had no clue about, and I could go to my room and read about them. So I learned later that an undergraduate should always keep it simple. Now for postgraduates, I like it because it's the work, teaching and So I like both. I probably prefer postgraduate slightly more
because it's more skill based.
Yes.
There's what you've just mentioned about how to teach. There's a girl on TikTok. She's a medical student in UN. I've forgotten her name, but she really talks about her medical school life, and she said something that actually relates to that. She said some lecturers, when they come to teach, the way they teach is like they don't want to teach, or the way they deliver the knowledge is not really up to the students. Don't get it. It's just like you're talking at people and they really don't understand. So I don't know. You mentioned the UK, but I think in the UK, people who teach have to have like training in teaching.
No. Medicine is an apprenticeship, so it doesn't matter where.
It doesn't matter.
You just teach it,
But do you think that's important?
I think it would help.
Yeah.
I think it would help. One of the things I've learned with there is an orthopedic organization called AO. It's really to do with fractures. And they really teach people. They really teach people how to teach and everything. So I think they would, but I don't think necessarily No, it's not.
But isn't it? And there are people who, first of all, enjoy teaching and are just naturally better teachers.
Yes.
But is there a screening mechanism? Because I think, I hate to say this, but I think over the years, the quality of the doctor at MO level or going into internship keeps going down.
Keep going down.
Could that be attributed to the quality of teaching? In your opinion?
I think maybe numbers. First, number one, there's always this thing that things are not as good. That is also something that sometimes is a myth, not based on science. Look here, when I was in medical school, we were about 100 students. Now, medical school has about 300, and the facilities have not improved. And it's more. So I think that, for that reason, that maybe that's a reason. But books are much more accessible now than they were then. With PDFs, you can get any book.
I've actually never owned a medical book.
So you see, and you've been reading medical textbooks. We'll not ask how. But that's the thing about it.
So you think numbers has more to do with it than?
I think numbers. That's what I believe. I think that.
What about the new medical school?
What do you mean?
Because during your days, I think it was just you guys, and Moi came in.
Moi was, I think, our class was probably the second class of Moi, or the first.
Okay, but now we have, I think it's 8 or 9. Is it 10?
Yes.
Medical schools, and I don't know. Some schools, are meant to understand that, for example, in the recent years, students who our undergrad at KU
Mm-hmm.
have been having to go all the way for their clinicals, to go all the way to Kiambu,
Yeah.
level 5, just to see patients and clerk and have their clinicals. And you look at Kiambu and you compare to Kenyatta Hospital, and the exposure is not the same.
I don't know. That's true and also not true. You don't need. You can have such a massive exposure. If the student in Kiambu is attending ward rounds and whatever, they're better off as a student in a big institution and they're not.
But also, I heard, because this is same Kiambu, because you hear stories like, the medical staff at Kiambu are not letting students see patients. They're denying students.
I'm not sure. I have a friend of mine who works in Kiambu and he teaches there.
He teaches.
So and it's
this from a student who was there. Anyway, let's take a short break.
No problem. Thanks.
All right. Welcome back.
Thank you.
Daktari.
Thanks.
So I think so far we've touched on most things, but there is something you mentioned that I don't know. It's true, but also unfair. You said medicine is a business. And the nature of business is such that they say willing seller, willing buyer. So ortho in itself, at least the ortho I have seen, and this is especially in the rural areas, tends to be quite draining and expensive for the patients, especially the ones who do not have insurance, the ones who have to pay from pocket, and maybe the resources are a bit limited. Yeah, I don't know. What's your experience with maybe patients being unable to afford your services?
I think that when I say medicine is a business, it may not be what I want it to be. I think that healthcare is a basic human right.
It is.
And everyone should get it, just like everyone would get education or everyone would get food. Yeah, you understand? Because if somebody cannot afford healthcare, I say, like, if you land in a public hospital that does not have facilities and you have a fracture and it's not fixed, a man will lose his job. When you lose your job, you could lose your marriage. When you lose your marriage, your kids cannot be catered for and everything. So
poverty continues.
Poverty continues. So I believe that. However, privately, whether you like it or you don't, it's a business.
It is.
It's just like any other, just like law is or being a carpenter is and everything. So that's number one. Number two, so I teach in the public hospital, and I work and I operate there, and I also do private clinics. So sometimes I tell people, look, if you cannot afford private healthcare, then you can come to the public hospital. Yeah.
How does that's KNH? How does KNH work in terms of providing maybe implants to those who can't afford?
I can't specifically talk about a specific hospital. But government hospitals, maybe they have a procurement system that they have and everything. But I would be lying if I said that I know the ins and outs of one.
Because where I work, it's a public hospital, and patients often have to foot the cost of the implant on their own. And for being a rural place, that's a place where 30,000 is a lot of money.
Of course,
it is a lot of money.
It varies from place to place.
Yeah, so. You find patients who definitely need an implant. Definitely. Look at them and you tell them you need an implant, but then there's nothing you can do because they can't afford.
Yeah.
So you end up on traction, for example, or on a back slab, and the healing is compromised. Some have open fracture and they can't even.
No, I can imagine. Sometimes public hospitals can be. Yeah.
In your experience, now that you're well traveled, you've worked in the NHS and all. What do you think would be a permanent solution to this?
I think it's political. Yeah, you can't solve the health problem unless you solve the political problem. So, better governance, accountability to people, and also the country just getting wealthier. If you got the right politics, the country gets wealthier. If the country gets wealthier, the people will always demand for good service. The only way to get rid of doctors' unemployment is to get the country wealthier.
country could have been wealthier by now if our
Well,
politicians
I don't want to talk so much about
into
politics,
Yeah, but you think it's a
but
political,
it's
a
political.
political thing.
You understand what I'm saying? If you look at a country like Denmark, I don't know what the population is, but it's between 5 and 10 million. And if you look at the population of Nairobi in the night, it is about, during the day, it's about that.
Yeah.
And yet you find this small country has got healthcare everywhere.
For
They have
everyone.
many hospitals.
Yeah.
You understand?
Accessible, affordable for
Yeah.
everyone.
So I think it's political.
I hope we get to that because it's really heartbreaking and unsatisfying.
It is.
You know, the way you can fix a fracture, broken bone, and you feel nice about it. Your patient who came on a wheelchair or stretcher is now walking out.
And also, I believe for a selfish reason.
Yeah.
This is what I believe. If we are to be a good private healthcare system, we have to have a good public healthcare system.
Yeah.
So somebody has to be trained
They
somewhere.
complement each other.
Oh, they do. If you've got a poor public system, you are not going to have a perfect. Because why do people train? People train in the public. Yeah.
Then that's true. So government, it's on the government.
It is. Healthcare is complex. Even in countries which are very wealthy, like America, healthcare is tough.
Yeah, here in America, it's very expensive.
It is. So it's very, very tough. So there has to be serious political will.
What about manufacturing? Because you work with implants like knees and all that. Are there any that are made locally, or do you have to import all of these things?
Wow. In orthopedics, none that I know is made locally. None.
Not even a simple plate?
No. But you see, that also comes with political will.
Yeah.
I'm not quite sure the government would say that, let's make plates. But if the country is growing, if the economy is growing, if everything is growing, then people will make plates and they will make seats.
Yeah.
I mean, the other day I went to buy seats and just office seats. I was shocked at how expensive they were. I was just buying an office seat with this. They're super expensive, 30-something thousand shillings, and they're imported.
For a seat.
You understand what I'm saying? And I said, man, these things can be made here.
So those are also imported?
Yeah, those are imported. Yeah.
I think if we fix
they are imported.
Yeah, I think if we...
So, they are imported.
Because when I was very super ambitious with businesses, I thought of the implant business, which many people do around there. But then I found that, there's no local provider.
There's none.
You have to import.
No, you have to import and everything. So when you import anything that's imported, the costs go high.
Expensive, yeah. Because if you look,
look here. If the economy grows, then somebody says there's a niche here.
Yeah, and then
I can produce. But now you don't want to build a factory which will cost you 50 million. I don't do business, and then you can't get buyers.
Pay taxes. All percentages.
Yeah, then you can't get work.
Yeah, you can't really deliver. Because I was seeing the implants from India actually. Yeah. And even when you look at how they're making, it's not really complex.
Oh yeah.
Yeah, and then their price is very cheap.
They're
very cheap.
But once they arrive here,
you're like, they sell because you look at a plate that people sell for 20,000. You can get it for I think $2 or $1, and you're like, what? Yeah, so I don't know.
It's possible. You just have to
have the goodwill.
Yeah.
Politically.
I think so.
Yeah. Have you ever worked outside Nairobi?
I worked in Mombasa. And I've operated in many theaters. I've operated in theaters in Mombasa, Kiambu,
everywhere.
Kirinyaga, Nyeri.
So since 1999 as a doctor, that's 25 good years. Wow.
I've done, lots of surgery.
You've done it all.
I've done Meru.
Do you still have...
I've done Baltimore, I've done Stoke, I've done Glasgow, Adelaide. So
done it all.
Yeah, I've done it all. I've operated in Nairobi Hospital, operated in Eastleigh.
So when it comes to ortho, the practice itself, do you still have ambitions? Like, do you still is there? Are you?
Yeah, I'm always looking to improve myself. I mean, there are surgeries that I used to be
still want-
excited about when I was a younger surgeon, not as much now. Some of them are just so complex that I probably could do them, but I just don't want the headache and the emotional baggage. Yeah.
So there's still a school ahead for you.
Of course, you never stop learning. Yeah.
So do you plan to do this until?
I don't know. I mean, time will tell. I'm not a believer of retirement.
Most doctors aren't.
Some do. If I probably will not be doing the same thing as I am, 20 years down the road. No, but I still plan to operate and teach to some extent.
To some extent. Okay. We most of us have benefited from your teaching.
Oh, thank you so much.
And we really appreciate it. There are some things, most of the things you treat, the plantar fasciitis, the things that we usually, some of us misdiagnose. Yeah, and I've actually had and this was back when I was in med school. I really didn't know much. But one of my aunt I don't know what surgery was done for calcaneal spar. That was
We rarely operate on it.
Yeah, so up to now, I still don't understand what surgery was done because I've never seen any surgeon recommending operation for plantar fasciitis. So
very rarely.
Yeah. Do you meet such cases like?
Maybe I would operate on plantar fasciitis. I see a lot of it.
Yeah, it's
maybe
a lot.
Once a year.
Yeah,
once or twice.
But it's operable.
Yes, sometimes if everything else fails. It's a last resort.
It's a last resort.
It's a last resort.
Have you met patients who've been mismanaged by maybe other cadres? Because not to speak ill of any cadre, but there was a circular that was going around, and clinical officers who go and specialize in orthopedics. These are persons who's done the 3 years of a clinical officer, then they do 1 year of ortho specialization, and I saw that they are allowed to now operate. Have you?
I don't want to talk about the specifics, but it takes 6 years to train a medical student. It takes 5 years to train an orthopedic surgeon and another year of fellowship. You just have to choose the person you want to operate on you or on somebody else. Yeah, they are. I'm an orthopedic surgeon. I've done this job for a long, long time, and I can do all orthopedic operations. So, and then surgery is not just the cutting; it's the thinking behind the cutting.
So I think we get to some point as a country, and then we just think some of these things can be done by anyone.
I mean, that's why I say, look here, I don't want to say this person should not operate here or this person should. That's you get what I'm saying. You have to choose whether or not you think you will be safe
under that person.
You understand what I'm saying? I'm a doctor and I'm trained to operate, but you have to choose whether you want me to do your hip replacement or your cesarean section.
It's up to you.
It's up to the patient.
So you'll introduce yourself and say, I know about bones.
Yeah.
But if you want me to operate, it's okay.
If no, I'll say that you have to choose. That's something that has to be. There is the law.
Yeah.
What the law acknowledges can be done, and there is the patient choice.
Yeah. So
you get what I'm saying? The patient has to choose.
All right, Daktari. Thank you for gracing us.
No problem. Thank you so much.
You also have, before I let you go,
yeah,
you have this. You told me you have a podcast for teaching.
It's called Ortho Tutorials. So I updated. I've not been updating it as much as I should, but I teach that, and then I have an Instagram page for teaching also called Ortho Tutorials. Yeah, just purely teaching orthopedics. I set questions.
Oh, you even set questions?
Yeah, it has a lot of questions for teaching ortho. It's mainly question-based. Exam-like questions that the undergraduate will get. Yeah.
So is there a subscription or?
Oh, really?
Totally free?
Yeah, it's free. So then I have my page which I run. That's more for the lay people, this procedure. But also tutorials is hardcore.
You do amazing. I don't think I can emphasize that enough. And we'd just like to encourage you to keep.
Oh, thank you so much.
Yeah,
Really,
because,
really appreciate it.
Yeah, even sometimes you can get a case and then you say, as I'm sending them maybe to the lab, you go to Dr. Oburu's page and check what he says about this, and it's really good.
Thank you so much.
Yeah, so
And
keep
a
it
real pleasure
Yeah.
coming here. Thanks.
Here at Daktari a Quick One, we appreciate you. And maybe I can tell you this, and also maybe that's my plan, my dream is to, have people like you who do all this and just say, thank you, Daktari, for teaching us. Thank you for, saving so many lives. Thank you for doing all these things as an acknowledgement.
No, thanks. The pleasure is mine. It's always medicine is an apprenticeship. So I've been teaching for a long time, and I'm going to continue teaching. A time will come when you have to exit the stage, and other people.
And other people. Yeah, there's a doctor who told me that at some point you're the one who will be replacing my hips. So I have to teach you again.
Yeah, that's true. All right, thank you so much.
Thank you, Daktari. Any parting shots before I let you go?
No, all the best to medical students.
Yeah.
It's tough times, but just keep at it. You'll be fine, and all the best to the general public. Doctors are here to help. Sometimes public thinks that we are not perfect. There is no surgeon. The only surgeon who has no complications is the one who doesn't operate.
Yeah.
But we want to get patients better.
Very last question. Would you advise someone who's just finishing their exams, or maybe KCSE, to go into medicine?
Yeah, why not? Go what you want to do.
Okay.
Yeah, you know what I'm saying. If you want to be a doctor, if you want to be a tailor, become a good tailor. If you want to be a chef,
be good at it.
Yeah, I think. Are you going to make a lot of money in medicine? I don't think.
Probably not.
Yeah. No.
So don't go in it for the money.
The days of making money in medicine are gone.
They are gone.
But it's not a bad job. Not bad for her.
Indeed, it's not. Yeah. So for the lovers of medicine, medicine loves you back. Somebody told me that the other day.
That's true.
Yeah. So Daktari, for your love for orthopedics, asante sana. I think probably I hope this episode gets one or two people going, I could also do this.
Right.
Yeah. So thank you.
Yeah, thanks.
Yeah, and from Daktari, a quick one. Please follow Daktari, Dr. Oburu Ezekiel. You'll find him everywhere. Like, subscribe. Also, down there, you can like, subscribe, leave a comment, and we'll be ready to engage. Adios. See you next time.
Adios.